delighted to be here. I'd like to thank Norma and the other members of the organising committee for Moving Points for inviting me here today. The title of my talk is Outcome Measurement, Peacock, and the Evidence for Improving Patient Care. I'll start today by doing a recap on what it is that we're looking at in terms of this whole idea of outcomes and quality in palliative care. And then look at the question, does outcome measurement improve patient care? Look at the evidence from a healthcare perspective, particularly a cancer perspective, and also the evidence from palliative care. I'm also going to look then at the palliative care outcomes collaboration in Ireland and maybe look at some of the more frequent questions that were asked as a Peacock team. A quick reminder of what it is that we're looking at from a quality perspective in healthcare. This is Avidas Donabedian, the famous Lebanese physician who really invented the whole idea of looking at quality in healthcare. And his model states that if you have the correct structures in place and the correct processes, that you're most likely to achieve the best outcomes for patients. And he states that we have to constantly measure and improve all aspects of this model to move towards a process of continuous quality improvement in patient care. So what we're talking about in relation to structural components of a service are the buildings, the constituent members of the multidisciplinary team and the healthcare staff, what x-ray machines maybe the organization has, or in palliative care, how many syringe drivers we have. When we're looking at processes, we're looking more at what it is that we do and how we give care. So that's really based around our professionalism, but also we have things like guidelines, policies, standard operating procedures and protocols to assist in that. From an outcomes perspective, we're looking at what actual health benefit is achieved by the patient, and this is called an outcome measure, or what change in patient experience is being produced. And when the patient actually scores this, it's called a patient-reported outcome measure. For the rest of today, I'm going to be very much focusing on this aspect of the model. So what are outcomes? Well, outcomes are really anything that's experienced by the patient, both good and bad. So for example, if you were a diabetic patient, it might be the level of your HbA1c. It might be survival in patients, their functional outcomes, how well are they able to get back to mobilizing and self-caring at home, discharges home from hospitals, rates of representation to hospitals, those type of things. When we're looking at patient-reported outcome measures, it's really what the patient experiences as the result of the system of care that we're providing. So their suffering or well-being, their symptom distress, their quality of life is a big one. So it's really the experience of what it is that we're doing for the patient. But where are we in relation to quality, both in healthcare and in palliative care? Well, since 2001, the National Advisory Committee report for palliative care, which is currently being updated, there's been a huge number of documents produced by the HSE nationally and internationally on key performance indicators, standards of care. There's been Q&I workbooks, there's been balanced scorecards for minimum data sets, competency frameworks, and guidelines from the National Clinical Effectiveness Committee. There have also been HSE corporate executive plans and 3-year development frameworks for palliative care. And during this time, there have also been a huge number of outcome measures suggested in the international literature. When I did a systematic review of outcome measures a few years ago, at that stage there was over 500. But don't worry about that. A lot of them weren't actually validated or worked through, but there's really been a huge amount of these things suggested over time. I think as a result of all of this focus and emphasis over the last 10 to 15 years, we're really in danger of becoming overloaded with the number of requests for data that we're receiving. And also the data that we're being asked to analyze. So I genuinely believe that in that situation, it's important to try and declutter the system and to try and keep things as simple as possible. So firstly, I'd like to look at does outcome measurement improve patient care? Because I think it's important that if we're actually looking at all this, we need to know first that this is actually going to help our patients. So firstly, does it help? Specifically patient-reported outcome measures. That's what I'm focusing on today. And let's look at what the evidence is. The first article that I'd like to look at was an article, a very rigorous study that was done by Jack Chen et al. In 2013. And this was published in the BMC Health Services Research. And it was a systematic review of the impact of routine collection of patient-reported outcome measures on patients, providers, and health organizations in an oncological setting. Now, this study was a comprehensive systematic review of all the evidence that was available between 2000 and 2011. And these studies were assessed using the GRADE criteria, which is a very well-validated tool for assessing the power of studies. Now, what he found was that there was 27 studies identified, and he found that there was strong evidence that well-implemented patient-reported outcome measures improved patient-provider communication and satisfaction. And he states that at that stage, there was emerging evidence that it improved the monitoring of treatment response and the detection of unrecognized problems. So he concluded by saying that despite the existence of significant gaps in the evidence base, there was at that stage growing evidence to support the routine collection of patient-reported outcome measures in enabling improved patient-centered care in a cancer setting. When actually going through this article, there's a large number of tables. It was almost at the level of strong international guidelines. It was such a rigorous study, and people are very free to go through that and assess the studies individually. But of note, just like to highlight that 15 of the studies reported either a strong or moderately positive impact on detecting unrecognized problems. So patient-reported outcome measures were found to be kind of a good flagging system for undetected problems. And 13 studies reported either a strong or modestly positive effect on changes to patient management. So 13 studies found that it positively impacted patient care. The next study that I'd like to look at is a study that was performed by Ethan Bash et al. In 2016 in Memorial Sloan Kettering in New York. And this was a randomized controlled trial looking at symptom monitoring with patient-reported outcome measures during routine cancer treatment. So in cancer patients, we know that patient cohort is a large kind of crossover with the patients that we would look after. The 766 patients were recruited for this RCT, and they monitored 12 symptoms by patient-reported outcome measures. Now, this was quite an interesting study because it was done in an outpatient setting. So patients are actually given handheld tablets, and they went home, and then on a daily basis, they inputted their symptoms into the tablets, or at a time when they would be having a more severe symptom. Physicians then received a printout of this symptom trajectory at each of the appointments, and nurses received emails, a kind of an email alert if a patient entered a symptom that was significantly severe. The outcomes that were measured were the health-related quality of life at 6 months, measured using the very well validated Euroqual EQ5D tool. What he found was that health-related quality of life improved more in the intervention group by actually more than double the usual care group, by 34% versus 18%. And in a cohort of patients where you'd expect quality of life to reduce over time, that is in advancing cancer, it actually worsened among fewer, 38% versus 53%. He also very significantly found that health-related quality of life deteriorated by much less, 1.4 points versus a 7.1 point drop in the intervention group, and that the intervention group were admitted less frequently. During the study period, 63% of the intervention group reported a severe symptom, and the nurses that were on duty at the time were able to cite action based on these email alerts. So it was a very good kind of early warning flag for nurses. So the conclusion of the study was that clinical benefits were associated with symptom self-reporting during cancer care. Now, the next actual article I'm going to look at actually wasn't a study, it was more kind of a review of evidence. That is the most up-to-date review that I could find for today. And this was published in the Medical Journal of Australia by Agarwal et al. In 2022, so this year. And the title of the article is Patient-Reported Outcome Measures, or PROMs, to Guide Clinical Care Recommendations and Challenges. Now, there's a large number of very interesting references in this article if people want to have a look at it, but I'm just going to read out the evaluation of all the literature that's out there. The use of systematically collected patient-reported outcome measures to inform the delivery of care has been researched for many years. Some of the references are there, with patient and health service impacts including reduced symptom burden, improved quality of life, and increased survival of patients with advanced cancer, and reduced emergency department presentations in a broad population of patients with cancer. And I think that's a very encouraging synopsis of what's available in terms of evidence, and that really, it's quite conclusive that they do positively impact patient care. Now, all of that was in the cancer setting, obviously, and I think the reason for that is that we're probably a little bit behind in terms of outcome measurement, etc., in palliative care, and we're only really coming to the table more in the last 10 years. But kind of the most recent review article that's been published was by Deborah Dudgeon in 2018, and she did a study on the impact of measuring patient-reported outcome measures on the quality of and access to palliative care. Now, what she found was that there were 6 systematic reviews and 47 studies looking at patient-reported outcome measures in a palliative care and advanced care cancer care setting. And what she states is that there's emerging evidence to suggest that their measurement improves outcomes and that they are important to patients. But what she very significantly identifies is that the Palliative Care Outcomes Collaboration in Australia is the only framework that has evaluated patient-reported outcome measures' impact on patient outcomes over time. And she alludes to this publication, which is by David Currow et al., which I'm going to look at in a second. And she states that this is the only one to demonstrate that patient-centered improvements in palliative care can be measured by using patient and family-centered outcomes derived at the point of care and tracked nationally. Now, for those who are listening today who don't know what Peacock is, I'll just do a very quick summary. Peacock is a national program that utilizes standardized clinical assessment tools to measure and benchmark patient outcomes in palliative care. And it does this by providing clinicians with validated clinical assessment tools to facilitate the routine collection of national palliative care data to drive quality improvement through reporting and benchmarking. Now, Peacock as an organization provides regular patient outcome reports and workshops to facilitate inter-service benchmarking, and it actually also actively helps to implement quality improvement initiatives in organizations. It also supports research by using a very large longitudinal database, which was used for the study that we're going to talk about. This is the Peacock tool itself. It's a clinical aid. It's a bedside tool that's kept beside the patient, and it's filled out on a daily basis and also at phase change. And the tool itself measures the phase of illness, and that can be stable, unstable, deteriorating, terminal, and bereaved. It measures the palliative care problem severity score, which measures pain, other symptoms all thrown into one, psychological distress, family care distress. These are all measured from 0 to 3, so the overall score is out of 12. There's 2 functional measures, the Resource Utilization Guide of Activities of Daily Living, or the RUG ADL, and the Australian Karnofsky's Performance Scale. And then there's the Patient Rated Symptom Assessment Scale, or SAS. So the study that Deborah Dudgeon was alluding to is this study done by David Currow et al. In 2015 and published in Support of Care and Cancer. So this study was titled Improving National Hospice Palliative Care Service Symptom Outcomes Systematically Through Point of Care Data Collection, Structured Feedback and Benchmarking. Now, what they did in this study is they actually anchored point of care data for the time period from July to December 2018. And over the next 3 years, they compared to this baseline in six monthly reporting cycles. So that was 3 years for all the services that routinely submitted data. There was 30 services that did that using individual longitudinal multi-level random coefficient models. So this really was the apex of rigorous statistical analysis. So data were analysed for about 20,000 patients, 46% were female, 85% had cancer, and around 30,000 episodes of care were measured, and 65,500 phases. So this is the benefit of having a very large longitudinal database. So what the study found was that there were significant improvements across all domains except for pain. So symptom control, family care, psychological and spiritual care, and then, but as I said, not for pain, and they're just looking at that a bit further to see why that is. They also found that the interquartile ranges also reduced for these domains over the period of the study, and that suggests that not only was the overall performance improving, but also that outcomes were being achieved more consistently. I had a little look at the statistical section of this article, and it looked very much like this to me, so I can guarantee you I won't be going through that today. Now, as far as I can tell, this is the first study to show that by implementing patient-reported outcome measures as part of a large national quality improvement program, patient-centered improvements can be delivered at a national level. But also that it's possible to work with services to systematically improve the care that we're providing in ways that we can measure using these kind of patient and family-centered outcomes. As I said, they're currently looking at why it was that pain was the only element of the tool not to improve over the 3-year cycle, and they're hoping to have some report on that in the next 18 months, I believe. Now, Peacock itself has now become an international initiative. It started off in Wollongong and Sydney in Australia, but it's now developed into something much more than that. Obviously, it's founded in Australia and is implemented widely there, but also in New Zealand, Germany. We're doing it here to varying levels in Ireland, and also in Singapore and Taiwan. They're at the early stages of considering it as well, and so are Canada and Japan as well. And this gives us the potential to benchmark internationally, and there's 20 benchmarks. One is on timeliness of care, one is on responsiveness to urgent needs, 6 are on pain management, 9 are on symptom management, and 3 are on family and carer problems. And here I just have an example of the first benchmarks, so people will know what a benchmark is like. It states it's the time from date ready for care to episode start, and it states that 90% of patients must have their episode commence on the day of or the day following date ready for care. And these benchmarks are normally set at the 20th percentile. So you can see in the report back that you get, the red line there is the benchmark, and the little dots are the services that are submitting data. You can see a large number of services are actually meeting and exceeding the benchmark, and a small number of services are actually moving up towards the benchmark. So that's the type of report that you get back. You also get these posters as part of the report package. So you get a very detailed report and a summary report. And this summary report is color coordinated. So you can see on the left hand side there is all the actual benchmarks, and this service is doing extremely well. It's meeting a large number of the benchmarks, and that's seen in green, and a small number of orange where they're actually moving towards the benchmark. And then there's other demographic data on the actual poster. I think it's very important to state that this is a very advanced service. Initially, services, when they get their reports back, they're nearly all orange, because it's all about inputting the correct data and then focusing on the areas to try and improve that data input and data tracking, and then focusing on trying to improve patient care. So how are we doing in relation to Peacock in this country? Well, at the moment we have some services that are actually collecting the data, and then some services that are submitting the data. We have about 9 services who are at the collecting stage, so they're trying to implement the tool and trying to get used to it. And then some services have actually moved towards submitting the data and uploading it for analysis with Peacock Australia. So that's Milford, Our Lady's Hospice, and Galway more recently. Now, a few questions that I'd like just to address. These are the most frequent questions that were asked in Peacock. I think we should just look at those so that we could maybe, I'm sure a lot of people have similar questions here. So the first one is Peacock validated? Secondly, has it been independently evaluated? Thirdly, is there any evidence it does anything? Is it going to be mandatory? Will it be tied to resourcing or funding? Is it national policy or will it be national? And can it be used to apply for resourcing? Well, the tool is actually validated to varying degrees, all elements of the tool. So the SAS is actually validated across settings. The problem severity score has been validated for reliability and acceptability. The AKPS is validated, and the RUG-ADL has been extensively validated, particularly in the care of the elderly setting in the United States of America. phase has been validated for inter-rater reliability in 2015. What if instead of going through all the studies here, because we don't have time today, it's a whole other kind of talk, is I've actually put together a repository of the most interesting articles and publications in relation to Peacock, including the validation studies, and that's freely available to anybody if they just contact the Peacock team in Milford Hospice. We'd be very happy to send that on to you. And I've also done a summary document just of trying to summarize the articles in about 3 lines so that people can actually look at this and see, you know, is that the article that they're looking for, and then they can look in the repository to find it. The next question that we've been asked is, has it been independently evaluated? Now, I'm not quite sure what that means, and that who would actually independently evaluate the whole of Peacock. But the actual Peacock tool itself has been evaluated in practice and is being researched in palliative care quite extensively. And these articles will be part of the repository that we're happy to disseminate. Is there any evidence it does anything? I'd like to say in a monopoly way, go back to start. I would hope that I've shown that there is significant evidence in the healthcare cancer setting, and that we're now at the point of actually developing evidence in palliative care. And I know that further follow-up studies to the 2015 David Currow article are underway in Australia and nearing completion. Is this going to be mandatory? Well, no, it's purely voluntary. This was never going to be mandatory in this country. However, engaging with continuous quality improvement, whatever way an organisation wants to do that, is mandatory for HSE funded organisations, but Peacock itself is by no way mandatory in this country. Will it be tied to resourcing or funding? Absolutely not. Because that would introduce this whole idea of gaming the system, and what that is where services would very understandably doctor or adjust their scores to try and secure more funding, and that would mean that really honest data wouldn't be submitted, because everybody would automatically be scoring nearly 100% in every benchmark. So obviously that can't happen, so it can never be tied to resourcing or funding, because it would totally just negate the whole program. So I'd like just to reassure people about that. But what I would like to say is that at the early stages, over the first number of years, organizations are not going to be meeting these benchmarks. And in fact, if organizations are meeting all the benchmarks initially, it's almost like something's wrong, because there is a diagnostic phase, which is the first few years, where organizations will be not meeting these benchmarks. And they'll be tidying up their data entries, they'll be improving and focusing on the various benchmarks, and then they'll move towards the benchmarks. But the expectation is not that they will be meeting the benchmarks, particularly in the early stages. Is it national policy? is the other thing I've been asked. And the answer is no, it's voluntary, but it is national policy to engage with continuous quality improvement, but not Peacock. Will anyone have access to this data in each of the organizations? And the answer is no. That's because of GDPR. However, organizational reports are held by the organization, and what we find is that organizations are actually quite proud of the fact that they're engaging with a very high-level international benchmarking system, because most clinical programs don't do that, and we're actually a leader in terms of healthcare in the country by going this far from a quality perspective. But the organizations hold the reports, and they are private and they are confidential. And even when we have national workshops, the services that are discussed at the workshops are anonymous, and we assign scrambled numbers to each service prior to the workshop, so only the service knows, for example, if service 6 is being discussed, who service 6 is. Can it be used to apply for resourcing? Well, a large part of securing resources, as anybody will attest to who's actually written a business case for securing resourcing, is actually to be able to highlight the benefit of the service for patient care. And this is especially, for example, in the palliative care setting, is how well we do this outside of the acute hospital setting. And this ties in with the whole idea of sláinte care, etc. And last year, Peacock won an international award at the EAPC for the best European paper in the Journal of Palliative Medicine. And the study that we did was, is inpatient hospice care clinically effective, using phase of illness to evaluate care outcomes for patients admitted to a specialist palliative care unit in Ireland. So we were able to demonstrate that we gave progressive, significant and linear improvements in pain, other symptoms, psychological and family and care distress. But most importantly, we were able to demonstrate that we were able to do this outside of the acute hospital setting. And when we received the award, it was said that the article itself had been downloaded over 1,000 times, and it's being used to apply for resourcing in various countries from a palliative care perspective. So that shows the benefit of actually tracking your symptoms and demonstrating the worth of your service for patient care outside of the acute hospital setting. One fear that people have said to me a number of times is that, will palliative care just become about numbers? And the answer is absolutely not. This is a simple bedside clinical aid, and it helps us to detect and evaluate and communicate, but it doesn't replace our professionalism or the care that we give. But I do understand that initially when organizations are implementing this, it can seem like we're focusing on numbers an awful lot because it's a change process, it's new, and a lot of the time we're trying to see, are we scoring the tools right? So for that phase of implementation, it can certainly seem we're focusing on numbers a lot, but then what we found is that it definitely improves patient communication, patient satisfaction. It improves patients' symptom distress, and also improves patients' quality of care. So I don't see how we could judge it to do anything other than complement the care that we give our patients. So in summary, Peacock is now being implemented in a number of sites across Ireland, and data submissions are being made to Peacock Australia from Ireland. These are GDPR compliant, and we've completed an enhanced data privacy impact assessment based on this. Reports are now being generated, and this can be challenging for organizations in the first for the first year or two, because really initially you just see that there's a lot of data missing, and the first thing you have to do is to get good at inputting the data and making sure that you're not missing data, but then you get better at it after a number of reports. We're performing a number of site visits with our team, and I'd like to thank everybody that we visited for all the tea and buns that we've received. I think we all put on weight after every visit, so I'd like to thank people. But one thing I did notice is that a very friendly community is being established. Now, palliative care is a very close community anyway in this country, but this is quite an exciting initiative, and anywhere that we visited, it certainly has seemed to me that it's a very much we're all in this together, and you know, it's improving patient care, and it's, you know, it helps us evaluate what it is that we're doing. So it's been a very, very positive response with a lovely atmosphere. So again, I'd like to thank everywhere that we visited for that. We're hoping to do a webinar in April on basically data submissions and the reports that we're getting back to help people with that, and then a conference and a workshop in November. So in conclusion, there's extensive evidence that patient-reported outcome measures positively impact the care that we give our patients. It improves communication, patient satisfaction, symptom and quality of life scores. Peacock is a simple assessment response framework that can be used as a bedside clinical aid to care, a flagging system for the early detection of changing clinical status, and as a tool to engage with this process of continuous quality improvement through benchmarking and indeed international benchmarking, and is a great way for us to learn from each other. It's not national policy, it's not mandatory, and it's not tied to funding, but I think it's a great way for us to work together, and that's my view. So I'd like to thank everyone for their kind attention for this talk, and I'm very happy to take questions now.